Good day. I'm Roy Simpson. I am Professor and Assistant Dean of Data Science Education at Emory University Nell Hodgson Woodruff School of Nursing and a member of the Distinguished Academy's AI Task Force, and your moderator for today for the policy dialogue hosted by the American Academy of Nursing. It is both a privilege and a personal honor to stand in this role as moderator. I would like to bring your attention to 3 points, and that is to remind you that we do have a closed caption available for this event if you are so needed. Following the presentation from our guest speakers, we will have a Q&A session. I hope you will join, and a recording of this policy dialogue will also be released to all attendees who registered for this wonderful event in the coming weeks. Before we get started, I want to take a moment to thank the fabulous AI Task Force, many of whom you'll meet today over the course of today's dialogue, and the leadership of the Academy who has supported this fabulous work. I want to begin by remembering our beloved and dear friend, President Dr. Linda Scott. Dr. Scott was instrumental in launching this task force during her time as the board, and we cherish her leadership during that time of our appointment. We carry her memory and her vision with us today, and we are forever grateful for the foundation she helped build with this AI task force. I also want to recognize Dr. Barbara Barksdale, who served as our board liaison at the time of the task force appointment and who now serves as our distinguished president of the Academy. Thank you, Dr. Barksdale, for your continued leadership and support of this group. Thank you to the Academy CEO, Dr. Suzanne Mayamato, and to Christine Murphy, our Chief Policy Officer, for helping us steadfast support of this committee's work. And to anyone I did not name directly, please know that we are deeply grateful for the support and time we've received. However, it came from so many of you, it's hard to name all. We are gathered more than 500 strong, one of our largest events, because of questions of profound consequences now stands at the center of healthcare, nursing practice, and public life. How do we harness the extraordinary promise of artificial intelligence while remaining steadfast to our commitment to human dignity, patient safety, and equitable care? The question did not have an easy answer. And so the American Academy of Nursing did what this organization has always done. It convened the brightest and best of minds, demanded intense rigor, and produced a document worthy of profession it represents. The AI position statement you will hear today discussed was more than a year in the making. It was not taken lightly. It was forged through careful dialogue, deliberation, robust debate, and an unwavering sense of duty to the patients and the communities we serve. I ask that you visit the Academy's website to read the full statement and to appreciate the depth of the work that each contributor brought to this effort. I also want to take a moment to acknowledge the members of the public that have joined us and the elected officials and their staff. It is quite important that we are able to share our policy professionals who have joined us today. Your presence signals something very important, that nursing's work of AI is not happening in isolation. It's happening in conversations with the communities, the institutions, and the patients and systems that this profession exists to serve. We are grateful for your engagement. Now, to the work before us. The dialogue will explore 3 urgent and interconnected pillars: privacy and data protection, governance and regulation of AI in healthcare, and the essential imperative of AI literacy for the nursing workforce. These are not abstract policy questions. These touch every bedside, every patient, every nurse, every clinic, every decision support tool, every patient who trusts a nurse who is the most trusted profession with their vulnerable moments at their time in their life. The Academy's position is clear. AI must augment the irreplaceable wisdom of nursing, never supplant it. Nurses must have a seat at the table where AI is designed, deployed, educated, and governed. and the public must be able to trust that the systems shaping the care, that they are transparent, they are equitable, and they are accountable. We will hear from our distinguished panelists and we'll open the floor for your questions because today is not a monologue, it is a dialogue, and your voice matters. It is now my distinct pleasure to introduce the Academy's committee right now that's going to serve as this dialogue. First, I'd like to introduce Dr. Connie Delaney. Connie, as many of us know in nursing, is a living legend and a professor and dean of the School of Nursing at the University of Minnesota. She served as Associate Director of Clinical Transformation Science Institute in Biomedical Informatics and Acting Director of the Institute for Health Information in the Academic Health Center from 2010 to 2015, and the Knowledge Generation Lead for the National Center for Interprofessional Practice and Education since its inception. She is clearly an elected fellow in the American Academy of Nursing, the American College of Medical Informatics, and the National Academies of Practice. Dr. Delaney is the first fellow in the College of Medical Informatics to serve as Dean of Nursing. Delaney was an inaugural appointee to the USA Health Information Technology Policy Committee, Office of the National Coordinator, and the Office of the Secretary of the U.S. Department of Health and Human Services. She is an active member in the nursing profession. Our second speaker will be Dr. Simmy King. Dr. King is a nurse leader, educator, and informaticist. She is currently serving as the Director of Nursing Education and Professional Development at Children's National Hospital. She is recognized for her expertise in nurse digital transformation, nursing transition to practice, education, and wellness strategies. Dr. King's leadership has earned the Children's National prestigious honors, including the ANCC Practice Transition Accreditation with distinction and the ANCC Wellbeing Excellence Credentialing. She has served as a board member of the American Organization of Nurse Leaders, the Virginia Organization of Nurse Leaders, and the DC Board of Nursing. She currently serves as the president of the American Board of Nursing for Artificial Intelligence. And we welcome Dr. King. And Dr. Mollie Cummins is our third speaker. She is the professor of nursing and adjunct professor of bioinformatics at the University of Utah, where she holds the distinguished John M. Huntsman Presidential Chair. With over 25 years of experience in artificial intelligence, Dr. Cummins is among the pioneers in artificial intelligence. She has done enormous work and co-leads the NIEHS-funded Smarter project, developing AI-enabled tools and resources to manage and use sensor metadata for environmental health research. She previously led NIH and AHRQ-funded digital health research to advance health informatics accessibility and interoperability. She currently serves as the editor of telehealth.org News, a publication actively covering scientific and policy developments in telehealth and digital health. And our fourth speaker is Dr. Jane Carrington. Dr. Carrington has 27 years of experience in nursing informatics as a clinical analyst, scientist, and educator. The focus of her research is nurse-to-nurse communication, which is extremely important and is part of the electronic health record system for patients with a change in condition. She has taught informatics in the Doctor of Nursing practice and the Doctor of Philosophy in Nursing. She is an active in American Academy of Nursing and the American Medical Informatics Association, and also served on the Academy's AI Task Force. Dr. Carrington retired as an associate professor from the University of Florida College of Nursing in May of 2025. Ladies and gentlemen, now please join me in welcoming the chair of the American Academy of AI Task Force, Dr. Connie Delaney, as she sets sails on the proceedings of today's dialogue and invites us all into the new world of nursing and artificial intelligence. Welcome.
Thank you, Roy. and a fullest gratitude for every one of you that have joined us today in this deeply serious and opportune time to serve our people. And as Roy said, our utmost confidence and commitment in preserving the trust of the people. I have the opportunity to share how it got from a concept to our actual work and publishing of a position paper. We are very fortunate that the Academy Board of Directors has been consistently addressing and following the trends of both the rise of legislation and regulatory policy priorities and the increased usage, particularly of generative AI-assisted applications and technologies. Our board of directors established, consequently, the AI Task Force in 2024. This task force is composed of 17 fellows of the Academy. Our charge was to make recommendations on health policy related to AI. The members represented not only health policy, but the nursing profession and the organization. There were many components to the charge. Allow me to just highlight 3. Our charge was to review the Academy's history on AI and information from organizations with similar policy-related goals. We did this to guide the Academy's response to the 5 identified key areas of AI from the White House. Second, we completed an environmental scan. The purpose of that scan was to identify key health policies that the Academy should address related to AI. These policy issues could include, but weren't limited to, addressing algorithmic biases in AI or making additional investments in AI research. And 3, what we're most focused on today is develop a position statement with policy recommendations that would allow our organization, the American Academy of Nursing, to respond to requests for information, proposed rules, and other opportunities to provide feedback on AI policy-related developments. And you notice we say developments. As Roy said, this is about being in the very beginning of dialogue and suggested innovation, etc. You may wonder how we then pursued addressing these charges. The task force, first of all, heard presentations from AI experts across policy, research, academia, practice, and industry on a whole variety of topics. These included patient safety, nursing science, and ethics. The speakers selected for our meeting were recommended by members of the task force, and they included representatives from the National Academy of Medicine, Duke University, University of Maryland, Epic, Mayo Clinic, Columbia University, and many others. After this landscape review, the task force focused on developing the Academy's position statement with policy recommendations that focused on various AI policy areas. We did something else. We also recognized there was a gap in nursing's voice in certain areas, specifically in the areas of data, privacy, and transparency. You're going to hear more about this from the other members of our panel today. This statement lends nursing's much needed input into these areas that I just mentioned, as well as research, ethics, bias, equity, practice, and regulation. We were intent on recognizing the gaps, addressing them, and ensuring that nursing has an impactful voice in framing policy. This draft policy statement went through multiple rounds through the task force. The Academy's board then approved the position statement in February of this year, and it was officially published, as you know, in March of 2026. It was released to the public, and it was also published in Nursing Outlook. The statement was sent to policymakers on Capitol Hill, including several key congressional committees who particularly have oversight on health and technology issues. This has been a robust process. Your task force members have been deeply dedicated, and we celebrate your review, feedback, and Q&A, as Roy said, related to this position statement. I now have the honor to turn the conversation over to Dr. Simmy King. Dr. King will address the Academy's focus areas within the AI position statement. Dr. King.
You're muted, Dr. King.
Yeah.
Muted.
Now you're
Apologies.
muted.
Apologies for being muted.
All right.
Good afternoon, everybody. Thank you, Connie, for providing an overview of the AI's task force charge and the rigor that was involved in developing the AI position statement with the policy recommendations. Now I'd like to dive a little bit into the position statement, as Connie mentioned, and the focus areas. But first, I want to emphasize that the position statement reinforces the need for the responsible and ethical use of AI as a transformative force in healthcare, one that ensures human wisdom and nursing clinical judgment are never replaced. Let's begin with privacy and data protection. The policy position paper, position statement helps us see that AI has introduced threats into our existing privacy laws where they weren't existing before. The use of AI in healthcare and research introduces new potential for security threats and data exposure. Data privacy could be at risk of breach, for instance, if personal health records were inappropriately used through a data source. Some of the issues we'll experience as we evolve with the AI use is structural. Many HIPAA standards predate modern AI, so they don't really address the challenges posed by adaptive algorithms, cloud-based model updates, or extensive data sharing that AI training often requires. That's why the statement suggests that HIPAA security rules need to be updated to draw upon contemporary cybersecurity frameworks, which might provide healthcare entities with clearer guidance on protecting data in an AI-driven environment. There's also a transparency gap. Often patients and clinicians aren't fully aware of how data is being used beyond the patient's own care plan. Healthcare organizations routinely sign business associate agreements, BBAs, that can permit fairly extensive data sharing and create ethical gaps in data governance. Even with existing protections under HIPAA privacy and security rules, individuals and clinicians don't always have the information or control that's needed to understand how their data is moving in this fast-changing environment. The Academy recommends strengthening standards under the HIPAA privacy rules to ensure that the BAAs, and other data sharing arrangements are more disclosed and more transparent. The reason behind this is that individuals need to receive clear, accessible information about how their data might be used. And they also need to have the option to opt out of how their data might be used. Another focus area within the position statement are the concepts of transparency and explainability. Transparency is about having clear, accessible information about how AI systems work. Where is the data drawn from? What's the purpose? What are the limits? Explainability is the ability to follow the reasoning behind a particular data output or decision. The statement suggests that we really must benefit and we really need to benefit from both transparency and explainability. For this reason, the Academy calls for mandatory disclosure when AI is being used to diagnose, triage, in treatment planning, with documentation, and decision support. Full disclosure must be meaningful. It must be in plain language that's explainable. It must address how the algorithms work and what their purpose is. What are the training sources, data sources for training? How might the model drift and how is it being monitored? And what are any known limitations or biases? The underlying idea is a simple one. Individuals, families, and clinicians have the right to know when and how AI is a part of their care. Additionally, as technology continues to evolve, the statement frames this is it can't be considered a one-time fix, and there must be ongoing work. The position statement suggests that we must have regular review and regular updating of federal privacy laws as data practices, interoperability needs, and new risks emerge that will be informed by evidence and clinical experience. This leads us to our third focus area, AI literacy. The position statement and my colleagues have already pointed out that there is a gap in our understanding of how AI impacts the healthcare workforce, and we know that it's already having some real consequences. What's behind that is, unlike traditional software where there might be some transparent logic, many AI models, especially those built on machine learning and deep learning, aren't necessarily explainable. They don't often tell us how they've reached to a conclusion. They may have incorrect outputs that might not be detectable. Large language models can also hallucinate, generating false information. And algorithms can drift and degrade over time as patterns shift. These gaps can pose real risks to patients and clinicians, including the possibility of misdiagnosis and difficult questions about autonomy and informed consent. One of the things that we really need to do is consider how nurses will use AI tools and have an understanding of the full picture of how underlying algorithms, data sources, potential biases, and security vulnerabilities impact their nursing practice. This is an area that deserves our attention. One way to think about that is AI literacy is longitudinal, a lifelong competency rather than a one-time training. We can't simply assume that once we've trained on how AI works or what AI is, that we're done. Education has to be central to our nursing workforce, and we have to build up AI literacy. We need to continuously develop, implement, and evaluate AI safely to understand that we are moving in a way that allows us to remain competent in a very fluid environment. This is a very important professional commitment and not just a single milestone. For our academic leaders and our nurse educators, there are curricular implications, and the statements point for a need to have a comprehensive AI fluency research to include competency frameworks, educational strategies, workforce readiness, and evaluating learner outcomes to help guide us today as well as in the future as we develop our workforce. AI literacy is also not just about nurses. Nurses can play a meaningful role in promoting AI literacy for our patients and communities. As educators and advocates, we are well positioned to share information and help protect our patients. Public awareness of AI in everyday life still varies, and nurses are often considered the most trusted and accessible people that can help bridge that gap. Greater transparency can also help us provide genuine support during an informed consent process so that patients better understand the scope of their data exposure, the potential vulnerabilities, and the possible long-term consequences. Most of this is hard to scale without a significant investment. Federal investment in AI literacy is vital to supporting the literacy we need for safe, responsible use of AI care. As I close, I want to pull together these threads. The Academy's position statement makes a thoughtful case that privacy, data protection, and AI literacy are not just peripheral concerns. They are truly foundational to using AI responsibly in healthcare. And underneath that is something that should ground us all. AI will not replace us. It will not replace our critical thinking or our clinical judgment as nurses or the human connection that we form in the nurse-patient relationship. What it can do is support us in being safer, more accountable, and when nurses, educators, researchers, and policymakers engage and collaborate to address this issue seriously, we can certainly align in developing our workforce towards leveraging AI effectively. Thank you. And now you hear more about the AI policy recommendations from Dr. Mollie Cummins. Mollie?
Thank you, Simmy. Miranda, could we pull up the slides, please? The Academy's recommendations correspond to 4 priority areas. First, privacy, transparency, and HIPAA, FDA regulation, algorithmic bias, and education, research, environment, and nursing practice. Next slide. Our first priority area is privacy, transparency, and HIPAA. Recommendation 1 calls for updating the HIPAA security rule to incorporate modern cybersecurity frameworks such as those from NIST and ISO. The HIPAA security rule is extremely important regulation. It is the rule that requires covered entities and business associates to implement safeguards that protect confidentiality, integrity, and availability of patients' protected health information. And that does include when that information is used with AI. Inadequate or missing risk analysis has been the most commonly identified security rule violation in OCR investigations. A proposed security rule update was announced by OCR at the end of 2024. It doesn't mandate NIST or ISO by name, but it does make their core controls mandatory. That proposed rule remains under review. It has not been finalized. Recommendation 2 calls for strengthening transparency in the handling of business associate agreements. Right now, organizations routinely sign BAAs with vendors that permit extensive data sharing with limited patient awareness. And vendors are quietly creating AI tools using patient data. And what's interesting about this is that they are not necessarily breaking any existing rules. We know now that millions of identifiable records can lawfully flow to an AI developer without any patient or clinician awareness. We think that patients should know if their data trains AI systems and that they should be able to opt out of non-treatment uses of their data if they choose to do so. Recommendation 3 is perhaps the most clinically immediate. Here we call for plain language disclosure every time AI is used in diagnosis, triage, documentation, or decision support, including disclosure of known limitations and how the algorithm may have changed over time, algorithmic drift. Again, a recommendation that we believe is critical for patient trust. Recommendation 4 calls for regular federal review cycles because the law simply cannot be written once and left alone. This technology is unfolding rapidly. The HIPAA security rule, the part governing cybersecurity, has not been substantively updated since 2013, with core requirements dating to 2003. It is time to do things differently. Recommendation, next slide. So priority area 2 is FDA regulation. Can nurses depend on the FDA to make sure clinical AI technology is safe and appropriate? Well, traditional FDA device approval was designed for static locked algorithms, but modern AI learns and updates autonomously, sometimes through the cloud, and the extent to which the FDA will regulate AI in healthcare remains to be seen. The Academy calls for harmonized lifecycle regulation built around 3 pillars: safety, transparency, and quality. Critically, this includes meaningful disclosure to end users, nurses, and patients when technology and algorithm changes, not just when it is first approved. We must remain vigilant to ensure that deregulatory pressure does not erode the safety and transparency standards that patients and clinicians depend on. Next slide, please. The next priority area, algorithmic bias. Bias in AI, it's not theoretical, it's well documented. It's often simply an unintended consequence of how these algorithms are trained on data. They learn by example. For example, there was a study published in the very reputable journal Science that found a widely used health risk algorithm assigned Black patients the same risk level as white patients, despite the Black patients being measurably sicker, because it used cost as a proxy for health need. The result was harmful. Black patients were systematically denied high-risk care management that they actually needed. Unless we actively address bias, AI will automate and amplify existing inequities rather than reduce them. So recommendation 6, we call for clarification and expansion of the ACA's section 1557 non-discrimination protections to AI-enabled decision support tools. OCR has clarified that AI-enabled decision support tools are covered. That piece is in place, but enforcement mechanisms remain unclear. And many healthcare entities simply don't have the tools and expertise to audit their AI systems. Recommendation 7 is to implement and sustain bias evaluation frameworks, technical, operational, system level, so that healthcare entities actually have the tools to audit their systems and protect patients. Next slide, please. The final recommendations address nursing's role and broader impact of AI adoption. Recommendation 8 calls for scalable education and workforce development to build AI literacy among nurses, the broader healthcare professional workforce, and individuals. They should support the fundamental AI literacy necessary for safe and responsible use of AI tools. Education is urgent and critically important, as Dr. Keene noted. Recommendation 9 calls for investment in nurse-led and interdisciplinary AI research. Of nearly 370 NIH-funded nursing and AI projects from 2013 to 2023, only about 30% were nurse-led, and that has to change. AI designed without nurse leadership optimizes for what's easy to measure instead of what matters to patients, because the relational, contextual work of nursing is invisible to developers who have never done it. Decades of health IT failures have shown us that IT tools imposed on nurses fail or get worked around. while tools designed by nurses get adopted. And adoption, not accuracy, is where most clinical AI actually fails. Recommendation 10 calls for sustainable AI standards. AI data centers consume enormous amounts of energy and water. We know this. And procurement decisions should account for carbon and sustainability footprints. In addition to the environmental and climate impacts, data centers compete with communities, including hospitals, for finite electricity and water. So unmeasured AI growth threatens the very grid reliability and water security that patient care pragmatically depends on. Recommendation 11 is perhaps the most critical recommendation that we make. Require human oversight standards in AI governance and organizational policies that preserve clinical judgment, accountability, and the centrality of the nurse-patient relationship. Nurse decision-making should be supported and enhanced, not replaced. And nurses should be accountable, engaged stewards of AI-enabled care. 12, we call for structured workflow impact assessments before any system is deployed that changes how nurses interact with patients, because these tools and alerting systems can have unintended consequences. And recommendation 13, nurse scientists and informaticists must be included in pre-market development, procurement decisions, governance committees, and post-market monitoring. Not consulted after the fact, included from the beginning, in the interest of innovation, safety, and delivering the very best patient care that nurses can deliver. Now I'll hand things over to my colleague, Dr. Carrington. Thank you.
Thank you. And thank you to my colleagues who have already presented the work done on the policy position statement. I have been charged with kind of forecasting the future. And what's interesting in listening to my colleagues, in many ways, the future is here. When I talk about what's coming, it is kind of already here. I will cover 3 questions. What is on the horizon for AI in healthcare? Has anything changed since the position statement has been released? And what considerations should be taken as the landscape continues to evolve? First of all, what's on the horizon for AI in healthcare? And those of you who know me know that my crystal ball gets cloudy sometimes it's crystal clear. So I think we're somewhere in the middle for this. But I divided it into 2 categories. First, technology, and second, policy. First of all, with technology, agentic AI, or AI systems that set and execute their own goals without human supervision, will do more than draft notes as they do now. They will do more complex multi-step tasks across applications. Precision and predictive care, causal AI and digital twins will be able to synthesize the entire patient profile and do predictive diagnosis years in advance. Massive remote patient monitoring, such as wearables, will advance to continuous AI analytics, resulting in data streams for active clinical triage tools, including early deterioration alerts. On-the-fly model creation using the EHR will advance to conversational type of AI that allows searching patient charts by voice, eliminating manual data digging. Now for policy on the horizon. And as an introduction, it's key to remember that AI is no longer experimental and is no longer in a pilot phase. Policies are becoming highly industry specific with enforceable frameworks to manage agentic AI. The challenge is finding the sweet spot between innovation and risk mitigation. So within policy on the horizon, there are 3 key points: strategic policy pillars, malpractice policies, and product liability. Within the strategic policy pillars, move towards adaptive regulatory clearance. For example, as my colleague already mentioned, the FDA has trended toward total product lifecycle oversight. manufacturers are required to pre-certify their algorithms and protocols so AI can update safely without new regulatory submission every few months. Standardized administrative and ambient AI, while very useful for reducing workload and burnout, federal guidelines are seeking standardized procurement of rules or securely tied to the EHR without exposing patient data, freeing clinicians to focus on high-level validation and patient care. Algorithm bias, as my colleagues mentioned, equity and training data integrity is the key. Emerging frameworks require strict data provenance and bias auditing, forcing developers to prove their training data sets are diverse, representative, and transparent. And then reimbursement frameworks. CMS is already approving specific billing codes for validated AI algorithms, and this will continue to advance. Malpractice policies are shifting from covering AI-related errors, implied coverage towards explicit scrutiny. The perspective is AI is a tool, not a peer. The human in the loop, as my colleague mentioned, some states have already passed laws requiring human in the loop verification requirement, where a human must perform independent review of the record and evidence of the review must be in the record. If hallucinations are not edited, it is assumed that is their own documentation error by insurance companies moving forward. To clarify product liability, malpractice, there are three components. Provider policy protects those from their own mistakes. Vendor policy protects from software defects. Here is the current gap. AI vendors include hold harmless clauses on liability. If AI fails due to a software bug, malpractice insurers may cover the patient claim, but may not be able to sue the vendor to get that money back. So in speaking to where we are, what has changed since the policy statement has been released, as evidenced by how fast this technology is moving, of course, there's been some changes or some advances. First, the executive order that was signed June 2nd, 2026, promoting advanced AI innovation and security. The components of the executive order, the federal government evaluates if a system is considered a frontier model based on real-world capabilities or potential to impact national security, and critical infrastructure core criteria are the following: advanced cyber and vulnerable capabilities, dynamic benchmarking or acknowledging AI as a moving target as this technology advances, and then high impact from commercial use software to severe harm. Once designated a frontier model, triggers voluntarily framework to balance security with innovation. The National Policy Framework for AI Directives, federal preemption over state laws, and this is a push for national uniformity to prevent a fractured or separated regulatory landscape versus purely state level, and included in the proposed legislation, the Trump America AI Act, that blocks states from enacting overreaching AI laws that hinder innovation. National security and cyber defense is the second point. National AI strategy is to treat frontier models as critical strategic assets. This links tech policy with national security. And then building the physical backbone for AI, data centers and power grids, as my colleague described, are massive power demands. And these have converted to energy policy, from energy policy into AI policy. And free speech and anti-censorship policies contain strict guardrails against AI models that perform ideological manipulation. And finally, intellectual property and digital replicas. Copyright takes a distinct wait-and-see approach at this point, retaining fair use as previously ruled by the Supreme Court. So what considerations should be taken as the AI landscape continues to evolve? Policymakers are tracking the following risks: dual use dilemma. And this is, for example, ensuring that AI used to design life-saving proteins can't be manipulated to synthesize novel biological threats. Liability and the black box, or liability for AI recommendations that are incorrect or hallucinations. Currently, consensus keeps malpractice liability on the human provider and demand AI literacy for credentialing. Resource gaps, and this has been existent for decades, flexible compliance standards for rural versus urban care systems with differences in technological resources and budget limitations. So looking again at my crystal ball and where we're going and what we should keep our eyes on as nurses and policy leaders, keep watching the connection between education or training providers to use AI and malpractice. This could move as AI gains even more sophistication. Federal government pushing innovation in cybersecurity and balance with state policies. Keep an eye on how states influence the national policy and how the national policy may actually take over this state. Approval guidelines such as FDA, as technology using AI gains more abilities and capabilities, keep an eye on how the approval process is going to take place. Watch the sweet spot that it's sustained between patient safety and innovation. We can expect future policies, especially through CMS, to tie AI usage directly to value-based care metrics, rewarding AI tools that prevent hospitalizations rather than merely processing data. In summary, for the future, my crystal ball, federal government AI-related policies are concerned with national security and innovation. And what's interesting here is both are being supported and encouraged. Healthcare AI continues to advance. AI as tool versus peer is going to be continued enforced with malpractice insurance, and AI literacy is going to be demanded for anyone who is taking care of patients in our healthcare systems. And the goal, advance AI capabilities while sustaining patient safety. And with that, I turn it over to my colleague, Dr. Topaz.
All right. Are we ready to summarize this whole thing? I think we are. So, thank you to all the panelists and thank you to all of today's speakers for this rich and timely discussion and description of the report that we have written. My role here is to briefly put together the major themes we heard today. The first theme is that nursing voice in AI policy is not optional. It is essential. The Academy's position statement responds to a moment where generative AI and broader AI tools are moving very quickly into healthcare and often faster than policy, education, or governance structures that can keep up. What we've heard today is that nurses bring a distinctive and necessary perspective because they understand workflow, patient safety, trust, equity, and the lived realities of care delivery. Second, privacy and data protection remain foundational. Existing privacy frameworks were not designed for the speed scale and complexity of today's AI system. If patients and clinicians do not know when AI is being used, how data are being handled, or what the limits of the systems are, trust is weakened. Transparency and explainability are not technical luxuries. They are basic requirements for safe and ethical care. Third, AI governance has to be life cycle governance. It cannot stop at development or approval. We need attention before tools are purchased, during implementation, and after deployment, with ongoing monitoring of real-world effects. That includes bias, safety, clinical validity, cybersecurity, and whether the technology is actually improving care rather than adding risk or burden. Fourth, algorithmic bias is a patient safety issue. AI systems trained on historical data can reproduce and amplify existing inequities. That means fairness evaluation, equity concerned research, and monitoring across populations have to be built into the process from the beginning. Fifth, AI literacy is now a professional responsibility. Nurses, healthcare leaders, educators, students, and patients all need the capacity to understand what AI can do, what it cannot do, and when human judgment must remain central. This cannot be a one-time training. It requires sustained investment in education and infrastructure. And finally, the future focus is clear. Nurses must be at the table where AI is designed, produced, implemented, regulated, and eventually evaluated. AI should augment nursing judgment, not replace it. The Academy statement gives us not only a set of recommendations, but a policy tool for shaping a safer, more transparent, and more equitable AI future in healthcare. With that, I'll turn it over to Dr. Delaney for closing remarks, I think. That's right. All right.
Yeah. So thank you very much, Max. And I think the Q&A has a major emphasis of our time together. And Roy, I will transition to you.
Well, thank you. I appreciate all the speakers, and now we are ready to engage with our questions. And I want to see if we have any questions in the chat. And it seems we do have a few questions. Let me see which. One is from Jenny Hansen. She says algorithms depend on extended databases, which are less than effectively constructed. Plus, we are now finally recognizing the importance of social determinants of health factors in health and healthcare, not historically collected. In using proxy data elements, our profession should be eagle-eyed, as well as potential voices and contributors to these factors that nursing historically has been known to care about and advocate for. So, do I have any comments or questions on the engagement of social determinants of health?
Roy, I would welcome making a comment. And
Okay.
the first is applauding Jenny's comments
Yeah.
on the importance, and just in a quick comment that would take longer discussion in terms of how we advance. This is indeed all about advancing not only the accuracy but the breadth of data that as you say, nursing practice represents on behalf of the patients, families, and communities. And so again, the teaming and working together, not only with nursing informatics, but the breadth of the health informatics world, which is all about data, and collecting and being able to share it is a priority. Thank you.
Good. Do you have any comments from any of the other panelists? And any questions? So I do have one question that has come forward. But where do you see the federal and state rights issues evolving? Each of you mentioned the need for federal engagement and our state right issues. Where does that put nursing in the context of licensure and engagement with the Multi-State Compact Act? Do I have any comments from anybody? You're muted, Mollie. If you can unmute.
I am unmuted from my end.
Oh, there you are now.
Okay, great. So it's clearly unresolved. The trend at the federal level has been to minimize regulation, deregulate. The states are trying to implement their own measures according to their preferences and decision making. And in some instances, like we're seeing in Colorado right now, we have Elon Musk and the federal government suing Colorado over the legislation they've created. So the state and federal lawmakers are coming into conflict with each other. So this is clearly unresolved. There are some creative solutions coming forward. Here in Utah, the state government has taken a regulatory sandbox approach where they're attempting to carve out systems and processes for vetting new technologies that navigate some of the current regulation, but essentially all of this is unresolved.
Any other comments from other people? Um, uh, um, we have a question from one of the audience people. Let's see. Miranda Harris has asked, they're flipping on me as fast as I can read them here. Should there be components of how to integrate AI into clinical settings be added to nursing curriculum? How should we address this in curriculum if AI literacy is about for everyone?
Well, I've been doing some work in that arena, and I
Good
can
deal.
say it's a twofold thing. That in my experience, I've seen this is actually twofold. One, to teach the students, we have to teach the faculty. So they go hand in hand. So faculty must also be competent with AI, understand the data flow to get to AI, and then how to work with it to then teach the students. And I've been a proponent for having AI taught not just in the classroom, but also in sim. The students should face these technologies in simulation to practice and get used to the process of using AI, the decision making that goes with it, and then the implementation. So that's where I come from with that topic, and I welcome my colleagues to continue.
Yeah, thank you,
Oh,
Jane. Just to build on that, so talking about how quickly this technology develops, right? And that's something that we try to address in the policy statement. Be sensitive to the fast pace of technology development, right? And so just building on your comment, I totally agree with educators that need to be familiar with AI. It is really hard to do these days. Even personally, I'm trying to keep up with AI developments, and they are happening every day, right? So it's really hard, and you need to go and really, and there is no courses, right? And people these days ask us for courses, right, on AI or something like that. I cannot recommend, frankly, things that are going to be up to date as of last week. That's the speed of AI development, right? And unfortunately, this is happening in the clinic as well. Those AI tools that are emerging or just emerged being put into the clinical practice, right? So the tools have changed. One example is ambient listening. This is a frequently used technology now, right? About 30% of US physicians have access to this technology, and it's rolling out fast to nursing. And this technology, we don't have it in the simulation settings. I know many schools are thinking about that, but that's just an example, right? It is based on generative AI, so it's somewhat dangerous. We don't know as much about that technology. It's really new. It's rolling out at a fast pace. And that's one of the challenges, right, that we have, and we try to address it in the policy, how you deal with that.
Good
No,
going, Max.
Roy, I was just going to also add, I think this part of the conversation is so critical about how do we prepare a workforce for something that feels very unpredictable, and is evolving at a pace that we can't keep up with. And recently, somebody asked me what are the competencies that nurses need to practice. And I said, some of them are not these technical competencies or fixed competencies, as I like to consider. Placing an IV, there's a competency attached to it. But I think about behavioral competencies that really need to be embedded in nursing curriculum, the adaptability, the agility to actually understand change management and to evolve with technology as a competency in our nursing curriculum so that we're producing a workforce that understands how to be adaptable and flexible when things are changing. Also, very contextual learning. We're not going to always understand the name of the tool or how the tool works, but we should understand use cases, and we should be able to understand in the context of application to other future use cases. And so I think that the opportunity that we have is to really think about how do we develop our faculty who are preparing our workforce of the future, and how do we prepare a workforce of the future looking at it through the lens of more behavioral competencies, some change management competencies, not trying to become technical experts necessarily on AI, but understanding contextually how AI can be applied. And another thing, speaking about ambient max, I was talking to somebody the other day about that as well. That brings about a different way of how we teach nurses to document, because now we say our assessments out loud. And what do you say in front of the patient and family? What if the patient's a certain age or the person in the room is not the caregiver? So it makes us have to rethink how we communicate with our patients in our practice settings, what we say, what we do. Again, those are competencies that we have to think about, behavioral competencies about how we practice nursing in this new age of AI technology.
Good, great comments. Any other person on the panel that hasn't spoken, please put your questions in the Q&A so that I can get them rather than the chat. So I'm not going back and forth here, although I can multitask. I don't want to miss. But one of the questions that has come up, and I'm going to try to summarize several of them into one question, and that has to do with workforce replacement. There is enormous dialogue on the Q&A and the chat about whether we really should be aware of workforce replacement. There's an alignment about virtual nursing and how it fits with the Nurse Practice Acts. And so I'm going to open it up for comments on, to me, it goes back to states' rights, which is where your Nurse Practice Act is, but I'm going to open it up. Jane, I saw you nod your head, so I'm going to give you a shout out.
I just am used to agreeing with you, Roy.
Wise woman.
Gosh. I don't even have the words just yet if somebody else wants to dive in.
Mollie, it's Simmy.
Yeah,
Max.
I would be happy to dive into this as well, because I think that, again, this is about reframing the idea of being replaced. I think that makes an assumption that all nursing does is a set of automated tasks, right? And that we're task oriented, and that is simply not true, right? We apply critical thinking, human judgment. We form human connections. Our work is so much more expansive than a list of tasks that are completed. And at a time where we worry about having enough human capital, right? We should actually think about what AI can do to support our need for human capital, and marry those ideas together and leverage AI in a way that it augments the work of nursing, so that nursing can actually excel at what nursing does well, and not be burdened by things that can be done by a machine. And so we really need to be at the table. This is why governance is so critical, which is why we need to have a voice in every nook and cranny where these discussions are happening, and inform policy so that our practice is preserved for what the intention is of our practice, and not a misleading mindset that we're replaceable.
Yeah.
Thank
you for that, Simmy. I'd like to build on what you were saying. And Mollie, I saw you were starting to talk. I'll be very, very brief. I'd like to add that the perspective that I have been saying over the last few years is nurses who will not use AI will be replaced, but those who learn to use it will not. And the key is really going towards that critical thinking and how we take the information given to us from the AI tools and how we apply it to the patient for patient safety and better outcomes. That's so since I was a nursing student 100 years ago, shortly after Florence died, um, we've been challenged with how to measure, how to teach critical thinking. And boy, is that not right now front and center with what we need our students to learn to go out and practice today and every day as technology continues to grow. Mollie, I yield to you.
Well, those are excellent points. I agree with both of you. I think we also have to acknowledge that we want our patients to have the best care. And while nurses cannot be replaced for the reasons that Dr. Carrington and Dr. King elucidated, there may be particular tasks or functions that nurses currently perform that at some point AI will perform it better and more safely. And that should be okay with us. But right now, out there in the real world, our hospitals, our healthcare systems are not set up to make that assessment, to monitor that technology in clinical settings, to monitor it over time, and ensure that that remains the case, even if it's initially true. We don't have the regulatory systems in place that we can feel confident that technologies are safe for use with our patients. And our workforce does not have the skill set to do this independently yet. We're not there yet. And that is one of the reasons that the Academy decided on calling for human oversight standards.
Max, I saw your hand up.
Yeah, thank you, Roy. And thanks for this wonderful discussion about AI replacing nursing, right? That it is a real thing. It happens in many other disciplines. One example, my team used to work with several programmers. We don't anymore because we can do some of those tasks that the programmers used to do for us. We can do them themselves in a much more streamlined way using the latest cutting-edge AI. Nursing in general, I think, is relatively safe from the job displacement with AI, as it was discussed. So I totally agree with that. And many others think that as well. If you look across the tech spectrum, big thinkers in tech, they see nursing as a profession that's going to stay there, right? In the age of AI. We do need nurses in this age. Now, a couple of caveats to that. As it was said, some of this technology that's going to support what we do, for example, ambient listening, if the promise fulfills itself with reduction of documentation burden, right? So reducing time to documentation, we spend today about 40%, 40% of our time in nursing, specifically documenting. If we're going to reduce some of that, this time has to be put back into patient care. And, some of the things we're seeing right now, right, when the time is saved, clinicians are getting higher patient load. So, these are some of the other policy issues, right, that we need to keep in mind when we think about how AI is going to affect our work. This is, I think, an important dialogue to have this time as sacred and give it back to us so we can do what we do best, educate patients, work with them on things. That's my take on it. Thank you.
So here is what is a very interesting question, and that is, and I'd like each of you to respond to it. What's the most optimistic hope for using AI? What do you think the most optimistic thing that we can expect out of the use of AI? Who wants to start it off? Because I think it's a great question. Go for it, Max.
Yeah,
Go.
I can start with a couple. So the most optimistic vision we have had is imagine a world with no documentation burden. You don't need to document anymore. You are there as a clinician taking care of your patients. You're educating, you're providing hands-on care, other things. This what AI can enable us to do if built correctly with appropriate safeguards. So this is that's one of the big promises for me is that this technology can really remove documentation essentially and capture that through audio, through video, through other means. It has other negative sides to that, right? Privacy, safety, but that's one of the big things that can potentially happen. The technology is there. It is pretty decent, and it's getting better by the day. So that's one thing, right? And another thing for me personally is providing personalized care at scale, at an unprecedented scale. AI can go today and scan for all the literature up to date right now and identify, build a personalized systematic review for a patient based on the most recent evidence. And AI does it better than humans these days. So that's another promise for me. This personalized knowledge merged with evidence that can be used as a suggestion to the clinician. That's another great promise for me. I'll stop here.
Great. Good going, Max. Who wants to go next?
I'll go next, Roy.
Go for it, Connie. Go for it.
I'd like to build on Max's comments in that one of my most optimistic views, building on what Max said, is that the relationship actually is not only visible, but actually has impact on our overall decision making, whether it's an individual, family, community, or organizations, as compared to the dominance of a financial or efficiency decision. So I think openly engaging AI can help us not only strive for that balance, or maybe not even a balance, but we have the values driving who we are as human beings and how it is that we most productively and live with one another in a most flourishing way.
Good verbiage. Jane or Mollie or Simmy, y'all want to comment? Anyone
I'll
on what
jump
they're
in.
optimistic in? Okay.
I'll jump in. Yeah. So I totally agree with Max about more precision medicine to personalized medicine for the individual, in terms of being able to access more data about that individual, not just data that's collected in the healthcare setting as well. To really think about social determinants of health, to think about the communities and where care is delivered for that individual. I think the accessibility to health information should also support accessibility to healthcare in an AI-driven ecosystem. So that's one thing that I think will hopefully help keep people healthier and help improve our whole healthcare ecosystem. Also wearing my well-being hat, I love that we say that if we can reduce documentation burden, we can give more time back to clinicians to be with patients. I actually think it also gives us more time to have respite at work and to not get burnt out and to be able to take the break and be well and help support our workforce retention issues, so that the work is not seemingly too much and I can't stay in it and I can't do it forever. That automation will augment the work of the clinician in such a way that they're able to really enjoy their work and be happy at work and stay in their jobs longer, because we need that to support our workforce demands as well. So that's another lens that I like to take on how AI can actually support our well-being of our healthcare professionals.
Good. Very, very articulate. Mollie, Jane, either one of you left? Comment?
Go ahead, Mollie, and I'll follow.
Okay. In effect, decentralization of care and health. We go from people in the hospitals, that's the only time we see them. That's the only time we collect data about them and really understand what their life is like, to understanding the whole picture, the exposome. When we talk about social determinants of health, those are external exposures that an individual experiences that can affect their health, their well-being, the medical diagnoses they might have in their lives, and also providing care to them in context at the same time. Decentralized care. The pandemic was transformative for telehealth. Everyone's used to it and using it. And that has become, it's like the railway tracks out west, with the golden spike that can pull everyone together. Telehealth now becomes the conduit for AI-enabled nursing care.
Yeah.
Jane.
Building on my colleagues and their wisdom, one of the perspectives I have held on to is advancing AI in healthcare will thin the walls of our healthcare system. I see it connecting with public health, community health, all the lifespan of care will connect. And I think as a nurse at the bedside, that's powerful to really start to understand what's going on in the patient, not just their home, but their community, their county, their state, wherever they're living. And then it will help us to understand geographically what's going on to anticipate the health needs of our patients as a population, not just the one in the bed. So I have said before that it will thin. It will not get rid of it. We need acute care. Right now, we need acute care and all that, but it will thin the wall.
Very, very well said. And one of our last questions has to do with what should we, as people who are on the call, as our academy members, as nurses in general, how do we get to the table to make sure we have a voice?
Well, I've been obnoxious to get to the table. You all know that. But I think I honestly think getting to the table is because you know what you're talking about,
Got you.
and you can say it in a way that others understand. I have been accused, I know you won't believe this, with informatics being very in our language and having to learn how to expand so that others outside of informatics can understand what we're talking about. And this is so true right now. The general public has got to understand what we're talking about. And to do that, we have to talk in a way that makes sense to the general public. And if you can do that, you find yourself at a table, especially an interdisciplinary table, that's represented by a variety of disciplines and expertise.
Any other comments on that?
Yeah.
Jane, I think, go for it, Max.
Yeah, right. And thank you, Jane, for starting this off. I think the table used to be that small, even a few years ago, right? We had a very small table in this informatics community, what we used to call informatics. Now with AI table, it got huge. So the table is huge. The opportunities are there, numerous of those. We are the last line of defense in a sense. Clinicians, right? Overall, nurses specifically, we are the last line of defense between the patient and the technology that's being put into practice on a daily basis across hospitals, across outpatient communities in the country, right? And in the world as well. So the table got bigger. We need to speak up when we see things. And even, again, going back to the example of ambient listening, this technology has so much promise. This technology has so much risk. We don't even know. So these technologies are usually put in by vendors. They do not report error risk well. So how many errors? We don't know specifically for many of those products. We need to be there and we need to be able to say, any clinician, right? Because you see this documentation that's being produced for you, you would see those errors pop up. And you need to speak up. You need to tell your hospital administration folks, you need to tell the vendor, hey, we're seeing that. So we don't end up in another era of like the report to err is human, where we found lots of issues and errors in healthcare that were affecting patient outcomes very negatively. I think we're going to get to some of that with AI, with the current technologies that have been put in practice without proper oversight. And that's what our report warns against. So we are the last line of defense. And also, all the responsibility is on us, right? When we use those tools are clinical decision support tools by design. They draft your documentation, but you sign it. They tell you recommendations about care, but you sign it again, right? So the responsibility is on you. And we do need to speak up a lot more, I think, these days with AI that's rapidly proliferating into practice.
And Roy, if I could add an additional comment
Of
to Max.
course.
Yes, we we're members of the Academy. And I think we have a robust organization that has recognized the need. We can partner, all of us, in doing a number of the activities, whether it was Jane or Max that outlined. So next steps, or what can we do about it? Absolutely contributing, being partner, and committed to making a difference and being at the tables. But we can do that through the power of all of us working together, and with the Academy and the Academy's partnerships with all significant organizations, whether in nursing or beyond.
Okay. I see our time is beginning to come to a close, and make sure we're focused in. I think those are all great discussion points. I'm sure there'll be many others. And with that, I'll turn it over to Connie to give our closing comments and to thank all the people who participated, all the people who attended, all the policy people who came engaged with us. We want to thank you for being part of our organizational structure, and look forward to seeing people in October at the Academy meeting. And with that, Connie, it's yours.
Well, thank you very much, Roy, and to again echo your summary comments. Absolutely. And with a particular emphasis on our opportunity to be together in person in October. I want to thank you, Roy, for your excellent job of emceeing this opportunity, and always with vibrancy and this mixture of expertise, inclusivity, and relationship. I want to thank all the speakers, and I particularly want to acknowledge the members of the AI task force. Again, to everyone, they have been absolutely committed and engaged, and provided to the Academy Board of Directors something that we can continue to work on. Thank you for the planning committee for today's webinar, and always lifting up the wonderful staff of the Academy that makes all this happen. Christine, Ellie, Madeline, and Miranda. So we are deeply thankful. My last comment is, as Roy shared in the beginning, this has been recorded. It's available. Each one of you that's been present is a hub to share, send out, and foster discussion, and us working together to make a difference. Thank you.
Thank you, Connie.